of Research, Evaluation and Insights for both leadership and lifelong learning and talent management. And the reason for coming along today is just to talk to you a little bit about some research that we've commissioned into health inequalities and the implications that has for leadership and for leaders, particularly with the development of integrated care systems, and just how we start to embed some of that knowledge. So the report itself is 60 pages long. Obviously, I'm not walking you through a 60-page report. I'm just going to share with you a few slides about our initial findings and what that means for leaders and what we need to do moving forward. And then I'm happy to have a conversation or take any questions afterwards. So I'm going to try and share my screen. Bear with me. This is where it all goes horribly wrong. So I think it's that one. If someone could let me know when they could see that, if they can see that. I'm hoping you can see a screen that just says tackling health inequalities.
Yep, we can see that, thank you.
Fabulous. I will put that onto slideshow then. Okay, so this was some research that was commissioned by the Leadership Academy and was carried out by an organisation called Inequalities, who do a lot of work in this area and work really closely with us as part of our faculty. So the research itself was split into two different areas, with the first one looking at ICS strategies and initiatives and a review of those and kind of what has happened in the establishment of some of those initial ICSs around health inequalities and their approaches to measuring success and impact, and some case studies, and then some useful background information about those interventions. And then the second piece was around leaders and leadership, and really starting to understand the characteristics and behaviours leaders will need to portray in order to start to tackle health inequalities, and actually what some of those key barriers and facilitators were. So just to take us back a step to health inequalities, one of the things we did find when we started doing the research is the understanding around what health inequalities are. And each different organisation had a different view potentially on what it meant to try and tackle health inequalities. So to give you a stat that one of our key stakeholders kind of articulated to us, living up in the Northeast. So it's an organisation there that's doing some really great work. They were talking about the fact that quite often when we talk about health inequalities, we talk about wealth and race. And that's not always the only issue. Undoubtedly, they are two of the biggest factors when it comes to inequality to access to healthcare, but they're not the only factors. So they were talking about access to green space, living in built up areas, access to jobs, so unemployment and transport links, all of these things that actually start to create a picture of what it means to live within health inequalities. And the stats they were talking about was actually their child poverty statistics. So just before COVID hit, obviously, the Office of National Statistics did their annual population stats, and they found that 4.3 million children live in poverty, which is a shocking figure in a first world country. So 33% of all children within the United Kingdom live under the poverty line. 26% of all white children and 46% of all Black or ethnic minority children are entitled to free school meals. And actually listening to that statistic as somebody who lives in the Southeast in a relatively affluent area was really shocking for me, to think that those children are not got access to the same things that potentially my children have access to. Something we really need to understand and to tackle. And that will have only got worse as part of COVID. So we know, having spoken to my counterparts at the Office of National Statistics who are doing some work in this area, we know that figure has risen quite significantly over the last 18 months, and they're doing some research into what that looks like now. So these 42 ICSs have really taken a wide approach to trying to tackle some of the health inequalities that are prevalent within their area. And we have to remember that they won't be the same for each of our systems. So for example, here within the Southeast, in the area that I live in, we have a really significant issue with teenage pregnancy. Although we are actually a relatively affluent area, actually we really struggle with teenage pregnancy and the access to suitable maternity provisions. So they will be different in every area, and therefore the approach needs to be different. We've looked at community and partnerships and working as anchor institutions and what that looks like, thinking about personalised care and how to prevent. So rather than just trying to tackle the problem, actually how to prevent it in the first place. And that was the key thing that came up as part of the research. At the minute, we're often focused on either defining the problem in terms of poor health outcomes, rather than actually trying to identify the solutions in terms of addressing the cause of the inequality in the first place. So we spend a long time looking at what's causing the problem rather than actually tackling the issue. What we found as well is that for, particularly as a result of COVID, a lot of healthcare had moved to a more digital space. So GP appointments now online. You have outpatients appointments happening in a virtual space or by telemed. Actually, this has increased the health inequalities in a number of different areas, in particular with those that have a high BAME community, where English may not be their first language, or for those with a elderly population. So those communities who maybe can't access or don't know how to access technology. And it's something that, speaking to Ola Arabi, she has spoken about the kind of digital poverty that's started, the digital inequality that we are starting to see as an emerging inequality within the system. So thinking about implications for leaders and leadership, we started talking to some leaders of some of the pilot ICSs and then of provider institutions as well, to really think about what does good leadership look like. So what we've established is that it evolves from moving from a directional approach to leadership. So moving away from telling people what to do and working in that very structured environment to actually being collaborative and transformative. So being willing to be challenged by others. So to give you an example of the difference between that kind of single organisation and what we need to move to from a systems leadership perspective to really tackle inequalities, moving from hierarchy and power-centred, territorial, professional-driven, self-centred and kind of short-term task-focused to a more multi-directional approach that's adaptive, that can cope with chaos and change, that can influence and it works on a place-based approach, rather so a whole system approach rather than individual issues, that is person-centred to be inclusive and really recognises the issues that the population that it serves faces. So some of the barriers that we found when we were looking at how people are tackling health inequalities are the lack of tools and resources. And that came front and centre with everybody we spoke to. The different governance and cultures that exist across integrated systems. They are often having to manage across different governance structures, and that can be really difficult to actually get consensus and agreement. Lack of diversity within leadership was apparent in every organisation that we spoke to. So actually leadership needs to represent the communities that it serves, and what we found is that it currently doesn't. We all know that if you have leadership that reflects the community that you serve, you undoubtedly contribute to better patient outcomes and more inclusive services. And that leads into that availability and suitability of future ICS leaders. So the King's Fund have raised concerns about succession planning for leaders of ICSs. And obviously at the minute we are recruiting to chairs and executive leaders of ICSs. And what we know is that many of those people are close to the end of their careers rather than the beginning, and that we don't have that diversity mix across candidates. digital exclusion being one of the key issues that are facing most patients at the minute. So a growing technological divide, both with our patients and with staff who are going to have to work in different ways, particularly as a result of COVID. And then obviously the pace of change. So the pandemic has highlighted not only major inequalities, but it has actually slowed down the development of our systems. And actually recovering is proving very difficult, and place-based partnerships are an absolute critical role within that. So as I'm sure you can imagine, leaders need to be skilled in understanding data, identifying and scaling innovation, and having a really strong focus on outcomes. They need to build strong relationships with other leaders and develop joint priorities and plans, and establish a governance structure that works across different organisations rather than competing ones. Setting objectives and outcomes, but ensuring that they delegate the day-to-day decision making so that we can cope with that pace of change, and understanding and leading cultural change, and really fostering a learning culture across the whole system so that we aren't afraid of failure, we aren't afraid to make mistakes and to not always get it right, but actually we thrive from that and we learn from that and build better. Our recommendations are to develop a robust evidence base, to have performance metrics in place that have a common suite of indicators, to appoint and support health inequalities leads, to ensure that the skills and capability and capacity of teams meet the new challenges that face us, to have diversity in leadership, to work within the gaps, so to understand what those gaps are, what are the inequalities facing your system, and to work within them, to tackle digital exclusion, and to ensure community engagement, and to balance service with targeted actions. So actually not just identify the problem, but actually source the solution and start to work on that. And then to share knowledge and best practice. And when we say to share knowledge, to share evidence of things that didn't go well. It's great to share best practice, but sometimes we take our key learning from the things that didn't always work. And then for leaders and leadership, we need our leaders to have an increased sphere of influence and to build relationships with one another and with their communities, to co-create and co-produce, and to innovate and improve. The placemake, so to actually look at healthcare at a place level rather than as we currently do, and to lead large-scale change, tackle complex challenges, to build commitment within organisations, and really to understand the role that anchor institutions play and the leadership that is needed for those, and then to deliver social change. So some of the next steps that we've got for our research to really start to underpin this and be able to produce bite-sized learning interventions and influence our national programmes are to work with some of our national programmes to identify the things that we could put into those. So working particularly with Leading for System Change and our Aspiring Chief Exec programme to think about some of the behavioural things that we need to put into those programmes to build our leaders. We want to develop sharing and best practice using mechanisms like our executive suite and Project M, and then build an evidence base for curriculum content. And then from a research perspective, we are conducting research into some of the pertinent areas of development for leaders. So I spoke about understanding data in order to make evidence-based decisions. We have some research ongoing in that area and in anchor institutions and in looking at systems leadership more broadly. And then to continue building partnerships. So we've got some really great partnerships currently with the Health Inequalities team, with ComFed and with the Health and Race Observatory. And so work in a really collaborative way so that our research can actually impact change and can help support the development of leaders both across ICSs, anchor institutions and the wider system in general. So I'm going to stop there. I'm going to stop sharing if I can. And I'm happy to take any questions or anything that anybody would kind of like to discuss. She says if she can stop sharing. Yep, there we go. I'm very conscious, hang on, I can't. Oh, so Nadia.
Hi, thank you ever so much for that. Just a very quick question about a step change, I think, in terms of leadership styles. You emphasised how important collaboration is, but bearing in mind what we've just been doing in terms of actually more command and control than we've ever done before, I just wondered whether you had any words around that transition in terms of change of mindset and change of the way in which we function.
Absolutely, yeah, and you're right. You know, we need to move to a more collaborative and inclusive partnership way of working, and we are just coming out of a complete command and control way of working. So we're currently doing some research into the vaccination programme and actually looking at collaboration that happened with the private sector. So thinking about how we rolled out vaccinations incredibly quickly by working in partnership, by utilising empty theatres and sports centres, and what that driver was that was needed to work in that way. So we've got some really good recommendations coming out of that. But I think it's a mindset change that's not going to be easy. We need to use our influence as the academy, our influence as a system to start to try and exhibit those behaviours and show that it is better to work within partnership. So utilising things like our executive suite, where we've got some resources on what it means to work in partnership, what it means to be collaborative, and how you start to show and exhibit those qualities in yourself. We're also using our competency framework to start to embed those within leaders. So building that evidence base and those competencies to measure ourselves as leaders and our leaders of systems against those to be able to ensure that we do have that approach. But I think it's going to take a while. We have moved to a more command and control. We have always, to a certain extent, as organisations, been command and control, been very hierarchical, and this is a real shift for lots and lots of our staff. So we need to understand where it works well and really embed that practice across the system.
Thank you.
I think I've got Caroline.
Hi.
Hi.
I might frame this a little bit clumsily. I couldn't order my thoughts really to definitely not trip over being slightly impolite. But with the formation of the ICS, there feels to be a kind of expectation on the ground that it will be exactly the same leaders that fill the positions of senior executives that we've already had, and like you say, you know, some of those will have vast experience but are approaching the end of their careers, and it feels like the ICS is actually limiting the number of opportunities for people to bridge that gap into more senior roles because there will be fewer of them. So I'd be interested in your view on how on earth we would go about succession planning when there are now fewer opportunities to step up, and possibly just a little bit of reluctance to bother even attempting it because it's still the same old boys club that it was, you know, the PCT, the CCG, you know, the hospital trust boards. And what that really means for aspiring leaders in the NHS.
I completely agree. I think some of the work that one of my teams have been doing around succession planning absolutely echoes everything you've just said. Less opportunities. It will be, you know, the chief exec of the local trust that undoubtedly becomes the chief exec of the ICS, or the person who's already doing it, or towards the end of their career. So how do we bring that succession planning in? How do we bring that new blood in? How do we stop it being an old boys club, for want of a better word? And I think that's where the kind of talent part of the Leadership Academy are working really hard within their regional teams to understand their ICSs and work with them on succession planning, on understanding the people that will be needed within these as they are developed. There is absolutely no way the vast majority of our current very executive leaders will understand green NHS, for example. I mean, I drive an electric car, but I'm not going to pretend that I am green. I feel like I do my bit, but I wouldn't have a clue on how to build a sustainable system. You know, that's not, it's not me, it's not my skill set. And that will be the same for many of our leaders. So what we're doing at the minute is identifying what the people look like who need to drive change within ICSs, within the system of the future, because they're the people we need to bring in now. We can identify those skills. We can establish that our current executives won't always have them. That doesn't mean they're null and void, but it means that we need to start planning for these new ideas, new thoughts, new leadership styles to come through. So that's what we're doing at the minute. We're doing some research into who are the people, who are the people we need to deliver digital healthcare, to deliver place healthcare, to deliver a green NHS by 2040. And then how do we start to find them? How do we succession plan with those people that are coming through now? I think it's a long-term plan. I think we know we have an issue with succession planning at the minute. We know that it's not going to be resolved overnight. When the ICSs are fully formed on the 1st of April, we are not going to have everybody in post that needs to be there, the right skill sets in place. But what we need to start doing is identifying what they are, who those people are, and how we encourage them to join us. And I think you know, the messenger review that's going to start happening will start to identify how we start to succession plan, how we start to develop our people a little bit. But I think it's a big piece of work that we need to get under the skin of, because we need to get those new skills coming through.
Lovely, thank you.
Can't see any more hands. No, brilliant. Anyone else got any other questions or any comments on the research? I'm happy to share. I'm happy to share the slides. I'm also, if anybody is interested in reading the full 60-page report, I am more than happy to share it. It is a thrilling read, but it is rather long. Absolutely no problem, Nadia. I will send you a copy of the slides. As I said, the research itself goes into a lot of depth. There's some really good case studies within it about what's happening in certain parts of the country where they've really got under the skin of health inequalities in their area. You know, bearing in mind that health inequalities, we talk about them as this big thing, but actually they're very different in each area. So being able to understand what it looks like in your area is really key, and the report really starts to articulate that. I think I've got a hand up. Caroline?
Hi, it's me again. If no one else has got anything to ask, I'm quite happy to keep
talking. Carry on.
So I'm seconded out of my substantive post at the moment to focus on a strategy for general practice that's a population health management model of delivery. So I've given myself 6 months to remodel primary care, which, you know, is ambitious. So, you know, reading the report sounds like it would be really useful. I'm in the first month and I'm focused on data. And I think what's becoming increasingly apparent is that there's so much data available, lots of different sources. Lots of people are spending lots of time curating data for us. But it's all disparate. It doesn't align in any kind of sensible fashion. Even the frequency with which the different metrics are updated doesn't align. So you've got one dashboard and the information is almost live, you know, last quarter. Another dashboard, the data isn't, you know, live. So it was uploaded in March, and that makes it really difficult to use that data consistently to paint a picture of your patient population, so you can get under the skin of who do I need to tackle. And that's when you fall back on gut instinct driven decisions about your intervention. So, you know, no one's going to argue with me that looked after children isn't a priority area to intervene, but there's nothing in the data that I can show that really highlights quite why it would be so important to put additional support in for those cohorts. So I think we've quite a long way to go, especially, you know, going down to the PCN level, about how do we find and use effectively all of these data sources to drive our decision making and monitor the impact of our interventions.
That's a really difficult. What I find leading a data team is that people use data in different ways as well. So actually, you're not comparing apples with apples either. Someone will find a data set and use it, but it doesn't necessarily always mean it's being used in the right way or for the right thing. What I would say, and I think Nadia's also put it in the chat box, is that the health inequalities team, led by Bola Al-Arbi, are actually creating a health inequalities dashboard at the minute, which will start to look at some of those things. I think numbers can tell you some things. I'm an analyst by background. I think numbers are great, but I think what it doesn't give you is the why and the what that means and the how.
Yeah, I don't know if that's is it the PAPI dashboard, that if it's that one, it's just sort of being promoted at the moment. I mean, I had a look at it, but again, the data was last uploaded the 31st of March. So it's 6 months out of date, and you really get to it's the so what.
Yeah, exactly.
You know, and I'm in one of the most deprived areas of the country. So what does a deprivation decile tell me about my population? Nothing. I need centiles, because 45% of my patient population are in the most deprived decile. So it's just about keeping on pushing for the usability of it. Actually, in my report I wrote, I think I probably need to feedback some of this as well to the people creating the dashboards.
Yeah, absolutely. And I would say it's worth always linking in with the Beneficial Changes Network as well, because they've been feeding in some really good research and resources into both the Health Inequalities team and into the Health and Race Observatory, who are also doing some work within this area. So having a chat with somebody there, and I can always put you in touch with people around what they're doing and the evidence base they have. Always worth there is lots of data out there, but some of it may be of real value to you.
Yeah, that would be superb. Any
connections? Yeah, I can ping you an email with details. I've got a couple of hands up. So I've got Charles and then Nicola.
Hello. I think this might be, I've got a question. I appreciate that there's probably not an answer to it. So I work in CQC. I'm in policy, and at this point in time, we're sort of exploring options and how to develop the regulatory frameworks and for ICSs, and how we, especially how we review ICS leaderships. And one key thing that keeps coming up is health inequalities, which thankfully we're having conversations about. If hypothetically speaking, if say we were to review an ICS, ICS leadership, and what steps they're looking or they're taking to tackle health inequalities in their areas, what I'm curious about is what sort of behaviors or qualitative or quantitative evidences do you think she'll be there and present to make things easier, to say an ICS to say, yes, this is how we're tackling, and this is the evidence we've got on how we're tackling inequalities. I appreciate that the answers aren't there. Even if the answers aren't there, what approaches, how do we go about it?
Absolutely. So the answers aren't always there, but as an ex-CQC member of staff, so I used to head up Spider Analytics at CQC. So I am with you on this. Actually, how we regulate and how we identify what good looks like within an ICS is going to be key. So I think certainly the Health Inequalities team, ourselves at the Leadership Academy, are identifying what those leadership behaviours and skills look like in order to address health inequalities. And as you start to build the framework and the kind of well-led framework around ICSs, that we need to work together both with them and with us as kind of leadership within the NHS to identify those key metrics that they should be looking for. A lot of it will be qualitative, obviously. That is unfortunately what happens with leadership. You can't measure it with a number always, but there are some key things that there will be some key metrics that we can be looking at as well. So I would say no quick wins, no quick answers, but would be, and again, I will share the report with you because there are some really key things on leadership in there about what a good ICS leader who's tackling health inequalities would look like. But do make sure you link in with Bola's team as well. Do link in with us, because as you start to build that framework, we would be really keen to support you with getting the right measures in place.
Cool. Yeah, looking forward to the report itself. I know it's 60 pages and
it's big report.
Yeah,
The health inequalities is a big thing.
It will be interesting to see what the key recommendations, or the key insights of that report. I'm dreading going through 60, but hopefully I should be able to.
Very well laid out. It's a really nice read, actually. It's a big
that is good
report,
to
but
know.
it's a nice read.
Nice. Thank you for that. Thank you so much.
Thank you very much. Nicola.
Yeah, thanks. It was more kind of a sort of observation, and you kind of sort of reflected on this anyway. I think one of the so I work in diversity and inclusion, but across quite a broad sort of remit and quite in a generalist way. But one of the things I notice is that it's very easy to get lost in what I heard somebody describe as the equality and inequalities data soup. And I think it's quite, I mean, I know that this is an emerging field and there is genuinely a lot of work to do around the data, but I think it's also quite important to move quite quickly away, because I think there can be a propensity to kind of focus on the data and the technicalities of that data rather than well, what does that mean? Because I think that whole piece about leadership around health equalities is something that we kind of need to get to quite quickly. But you kind of, I'm telling you kind of what you already know, but I think it is quite easy to get lost in that soup of kind of metrics, because the sad fact is, and we kind of all know this, that the data, whatever form it takes and whatever report it comes through, tends to tell us the same, unfortunately. And I know the work around the sort of locality and regional differences is a lot more nuanced and kind of new. But I kind of think in some ways we probably already know what the data is going to tell us. But yeah, I just wanted to say that out loud. I hope you don't mind.
I think we do, don't we? We know what the data is going to tell us, and we know that it's not going to shift quickly either. So, if your child obesity rate goes down by 1 point, does that mean you've tackled health inequalities? No, that means you've made a small difference in child obesity levels. It's the whole package, isn't it? And we can get bogged down in the data. That's the problem. We can spend so long looking at what the data is telling us that we don't really think about what the solution might be. And those will be different on a location by location basis. So what we're looking to do, particularly kind of as a leadership academy, share the stuff that works. Someone's had a really good initiative that's making a difference. Let's not keep it in isolation. Let's share it. Let's share what didn't work. We thought we tried this and it didn't make any difference at all. That's really important learning. And actually the so what is what will start to make the difference rather than the dashboard number.
I mean, one of the things that does occur to me, so I kind of don't know if I've got this right, but I did have something somebody said led me to believe that the HLM leadership framework is currently being looked at.
Yes, currently being reworked. It's due to be refreshed.
Yeah, and I think there is a sort of a broader question about the extent to which, if there are opportunities like that, particularly around the leadership healthcare model, perhaps the talent agenda, to kind of weave some of this in around health equalities in a more formalised way, so that it's a kind of, visible as a kind of accepted competence and that kind of thing.
It will be in the healthcare leadership model. So HLM currently isn't really fit for purpose for ICSs. It wasn't, it was 7 years old. It was very much provider territory. So obviously it's being recommissioned and reworked with obviously a focus on integrated care systems as well. But it will also have to have things like competencies around health inequalities, competencies around the green agenda, competencies around digital. So they are all being worked into it.
Great stuff. That sounds really good. Thanks.
Okay. Any other thoughts or questions? Otherwise, Jake, I don't know when we're due back to the main room.
Hi, we're due back in about 2 minutes time, so if there's no more questions, then by all means take a quick break. If you do need the link, I have posted that in the chat as well, so but I'll hang about in case there's any technical difficulties as well. Thanks.
Jake, are you happy if I send you the slides and the report? Are you happy to send them on to people?
Yes, please.
Perfect, thank you.
Thanks.
Thank you very much.
Sorry, is there a sort of time frame for the new leadership model? I know it's tricky at the minute because
So it should be April.
April. All right, cool. Thanks.